Anthony DiGiorgio is going to talk to us a little bit about the spinal cord injury in the elderly.
Okay, thank you, Dr. Sai, Dr. Dahl, for allowing me to come speak today. My talk's going to be a little bit more depressing because we're talking about, I think, a relatively difficult population to treat here. My disclosures are not relevant. So I want to bring up a case, a 76-year-old with sick sinus syndrome. He's got a pacemaker. His pacemaker misfires. He has a syncopal episode, falls backwards, wakes up with neck pain and can't move his legs. How we treat this patient, I think, really depends on his age and on his comorbidities. If you're 76-year-old, he wants everything done, you probably don't hesitate to take this to the OR. But what if he's 86? What if he's 96? What kind of discussions are you going to have with that family? And I think there's a bit of nihilism. I think some of us are a bit too nihilistic, but at the same time, we have to have realistic conversations with these families, let them know what we think is the actual chance of having a meaningful recovery and what the quality of life is going to be like for these patients in their remaining years. So again, on this patient, I think we all agree, technically we know what to do here. There's no question this patient needs to go to the OR. They need to go as soon as possible. If this is a 38-year-old, you're not hesitating on pulling the trigger. And at our shop, we're taking this in the middle of the night if it comes in then. But again, if this patient is 78, 88, with a sick heart, with a pacemaker, other comorbidities, what sort of conversations are we going to have with the family and how we're going to coach them through what an expected outcome will be in this case? The basics of spine trauma care, again, I think the first two rows here, we all know what to do. We know that the treatment starts as soon as they hit the ER. We know that we have to worry about things like neurocardiogenic shock and respiratory failure. Even in a low C-spine injury, patients can lose 50% of their vital capacity because they can no longer breathe with their abdominals and intercostal muscles. So we have to be aware of that in elderly patients. They have less respiratory reserve to begin with. We know, again, that they need emergent decompression and stabilization. There's no question there. And then the supportive care. What do we do about spinal cord perfusion? And then what do we have to watch for these patients in the intensive care unit? I think that's where a lot of the nuance comes in with these elderly patients. So in prevention of secondary injury, a lot of that came out of our shop when we were looking at patients who converted in Asia grade and found that these patients that had an improvement in Asia grade were those that had higher mean arterial pressures over the first 3 days of their following their injury. And that led to this concept of spinal perfusion pressure, where now it is a Class 3 guideline that we keep the mean arterial pressure elevated for the first 7 days following spinal cord injury. Again, I don't think any of this is controversial. The question is, what do we do in this patient who already has a sick heart, who's elderly? Dr. Dahl looked at this at UCSF when he was there, looked at intensive spinal cord injury, intensive management of spinal cord injury in elderly patients, compared those less than 70 to those greater than 70, and found that there was a significant complication rate, and those above 70 is about 73%. There's a significant death rate. About 13% of patients did not survive their hospitalization. Far greater number of those elderly patients end up going to a skilled nursing facility rather than rehab. But in this retrospective review, they did find that about 40% did improve at least one Asia grade by the time they were discharged. So there is a little bit of nihilism. A 13% chance of death is nothing to laugh at, but there is a chance for some recovery. We looked at our prospective database again to validate these findings in the TRACK SCI registry. And again, we found that a similar death rate, about 10% died with another 2.5% going to hospice. We did not find as great of an improvement at AIS at discharge. We only had about a 7.5% rate of AIS improvement at discharge. But the notable thing about our paper was that there was a 100% complication rate. Every single one of these patients over the age of 65 had some sort of complication during their hospitalization. And again, that's valuable information when we're talking with these families about what they can expect. There's going to be a long hospital course. There's going to be about a 10% chance that they will not survive. And there's a lower chance that they're going to have a improvement in their AIS grade. The notable thing when we broke down the different types of complications, the cardiovascular complications in patients who received vasopressors after their injury was significantly higher in patients that did not receive vasopressors. So we have to revisit this idea of mean arterial pressure elevation in these patients and really take a step back and think of if we're causing more harm than good by pushing these mean arterial pressures up with vasopressors. And so we've really moved to the spinal cord perfusion pressure model that was brought up by Brian Kwan's work out of Canada, where we realized that spinal cord perfusion pressure, the mean arterial pressure minus the intrathecal pressure, is actually a greater predictor of outcome. And by monitoring this, we're able to use a little bit less pressor usage, because if we think of what our traumatic brain injury colleagues do, they don't just drive the arterial pressure up to treat ICP, they also drain CSF and they monitor the intrathecal pressure with an extraventricular drain. So we do the same thing with a lumbar drain in all our patients. This is some of the data out of England where they look at the site of injury pressure and realize that there is even a difference between the pressure at the site of injury versus the pressure in the lumbar cistern. I wanted to mention briefly central cord. I think Dr. Harrop did a great job covering this, and the take-home message that it is safe to take these central cord patients because a lot of these are elderly. It is safe to take them emergently. So my conclusions, don't be nihilistic, but do have realistic conversations with your families. Be judicious about your pressor use, and then all patients, even central cord patients, go to the OR as soon as possible. Thank you very much.